ಏನಂತ ಬರೀ ಟೆನ್ಷನ್ ಇರಲಿಲ್ಲ ಸರ್ ಎಲ್ಲ ಸರಿ ಇತ್ತು. ಏನಿರಲಿಲ್ಲ ಮ್ಯಾಮ್, ಇದೇ ಅವ್ರಿಗೆ ಒಂದು ನ್ಯಾಷನಲ್ ಟೆನ್ಷನ್ ಬಿಡ್ರಿ, ಅದೇ ಒಂದಿತ್ತು. Good morning, students. Good morning. Are you able to hear me?
Yes, ma'am.
Good morning, ma'am.
Yeah. How are all of you? How are all of you?
Fine, ma'am.
All are fine? Yes, be safe. Okay, don't go out unnecessary. You heard of sad demise of our Vice Chancellor, sir? Yes or no?
Yes, ma'am.
Yeah, on 12th May, it was very shocking for all of us. Pray for him. Okay?
Yes, ma'am.
So, what I have covered in the last classes, will you remember? What all I have covered? Yes. What all we have covered? Yes? You remember me or not? Which topic I am taking, who I am? Yes, no? Hello? No response. What we have discussed previous classes? Which system at least?
Respiratory.
Yes? Which system? Huh?
Respiratory.
Yeah, respiratory system. So we have discussed about the introduction to the respiratory system, isn't it? Respiratory apparatus. Then we have started mechanics of breathing, isn't it? In that we have studied the mechanics of breathing, that is the mechanism of inspiration and expiration, what all changes occurs in the chest and in the lungs and pleural cavity, what and alveoli, what are all the pressure changes which occurs. These all things we discussed. Yes or no? So now today this class we will discuss about the different lung volumes and capacities. Okay, you will be learning this in your practicals also. Okay, so spirometry is one of the important practical for you people. Okay, we have recording spirometry as well as simple spirometry also. Okay, in simple spirometry you will be studying about the effect of posture and vital capacity, and in recording spirometry you will be recording all the lung volumes and capacities. Okay, so this is a very important practical for you, and as far as theory aspect, this topic is very important in respiratory system. Okay, so in mechanics of breathing only it comes, that is different lung volumes and capacities. Okay, so lung volumes are static volumes. Static means the time factor has not considered. Okay, air breathed by an individual, that is volume of air present in the lung under specific position of the thorax. There are 4 lung volumes. They depends on age of an individual, weight of an individual, build of an individual, gender, male and female, and body position. These are all the factors which affect our lung volumes, that is age, weight, gender, body weight, hmm, exercise, built. Okay. Then if we combine two or more volumes, that is called as capacity. Capacity is nothing but combination of two or more lung volumes. So lung volumes and capacities are broadly classified as static lung volumes and capacities and dynamic lung volumes and capacities. Okay, static lung volumes and capacities are, here there is no time factor is considered. Okay, so for example, tidal volume. Tidal volume is 500 ml. So the unit for the static lung volumes and capacities is ml or liter, milliliter or liter. Here the time factor is not considered. Whereas the dynamic lung volumes and capacities, here the time factor is considered. Okay, like FEV1, force expiratory volume in 1 second or first second. Okay, here the time factor is considered, hence the unit will be ml per minute or liters per minute. Okay, are you understanding? So static lung volumes and capacities are where the time factor is not considered, like tidal volume, inspiratory reserve volume, expiratory reserve volume, like that. Okay. Dynamic lung volumes and capacities are, here the time factor is considered, like FEV1, FEV2, FEV3. Okay, forced vital capacity or timed vital capacity. Okay, so these are all the dynamic lung volumes and capacities. Okay, so coming on to the static lung volumes. Okay, there are four static lung volumes, that is tidal volume, residual volume, expiratory reserve volume and inspiratory reserve volume. You must remember all these things and it should be on your tips. Always it will be asked the definition and normal value even in practical or even in the viva. Okay, it's a basic of pulmonary function tests. Okay, so tidal volume is the volume of air breathed in or out of the lungs during quiet respiration or during normal respiration. Okay, that is tidal volume. That is volume of air breathed in or out of the lungs during quiet respiration. Normally it is 500 ml. Okay, normally. Okay, if I am sitting, I am breathing in and breathing out. Okay, that is tidal volume and that is around 500 ml. Okay, then residual volume. Residual volume, the name itself indicate the volume of air left in the lungs after a maximum forced expiration. Okay, so the volume of air which left in the lung after a maximum forced expiration, this is called as residual volume. Volume of air which remains in the lung. Okay, it's around 1200 ml or 1.2 liters. Okay, then expiratory reserve volume. Expiratory reserve volume is the volume of air that is expelled from the lungs during a maximum force expiration that starts at the end of normal tidal expiration. Okay, so normal tidal expiration is around 500 ml, that is tidal volume. Okay, about that forcefully how much we can expire after normal expiration, that is called as expiratory reserve volume. Okay, that is around 750 to 1000 ml. Okay, then inspiratory reserve volume. So the volume of air that is inhaled into the lungs during a maximum force inspiration starting at the end of a normal tidal inspiration. So after my normal tidal volume of inspiratory tidal volume, how much I can take inside by my effort, deep inspiration. Okay, that is called as inspiratory reserve volume. Okay, that is around 2000 to 3200 ml. That is 2 liters to 3.2 liters. So these are the static lung volumes. Okay, all these things, all the lung volumes you can measure by recording spirometry except residual volume. Residual volume you cannot measure by spirometry. Why? Why means whatever you have expired, the spirometer will record that. Residual volume remains in your lungs. So you cannot record residual volume by spirometry. Okay, this you must remember. Then what are the other alternative methods to measure this residual volume? Okay, this is a homework for you people. Okay, read about this. Okay, what are the methods by which residual volume can be calculated or measured? This is a home assignment for all of you people. Okay, as I told, it cannot be recorded by simple spirometry. Then what are the other methods? You find out, you will be telling this to me in the next class. Okay. Yes. Next is static lung capacities. Okay. So as I told you already, capacities are combination of two or more lung volumes. That is called as capacities. Okay. So first one is functional residual capacity. So functional residual capacity is nothing but the volume of air remaining in the lung at the end of normal tidal expiration. Okay, so after normal expiration, whatever amount of air which remains in the lung, that is called as functional residual capacity. So this includes FRC is the product of residual volume plus expiratory reserve volume, because we are not expiring forcefully. Okay, so after tidal expiration, whatever amount of air remains in the lung, that is called as functional residual capacity, that is 2.5 liters is it is the normal value of functional residual capacity. So this functional residual capacity has very important physiological importance. So if this would not have been there in our lungs, imagine, okay, we will inspire 500 ml and expire 500 ml. Okay, so when we inspire 500 ml, there is an enormous air for gaseous exchange, isn't it? Okay, so there is the excess air is available in the lungs for gaseous exchange. But when we expire 500 ml, nothing would have been remained in the lungs for the gaseous exchange, isn't it? Our alveoli must have collapsed and no exchange would have been taken place during expiration if there would not have been any functional residual capacity. So the function of functional residual capacity is it maintains the continuous exchange of gases even in inspiration as well as in the expiration. Okay, because this is the amount of air which remains in our lungs after normal expiration. So this is very important capacities. Okay, that is functional residual capacity, and its physiological importance is it helps in the continuous gaseous exchange. Okay, it helps in the gaseous exchange. Now, inspiratory capacity. Inspiratory capacity is nothing but the volume of air that is inhaled into the lungs during a maximum force inspiratory effort that begins at the end of a normal tidal expiration. So, it is volume of air inhaled into the lungs during maximum force inspiration after a normal tidal expiration. So, this involves inspiratory capacity is equal to tidal volume plus inspiratory reserve volume. Okay, approximately on an average it is around 3 liters. Okay, this is the inspiratory capacity. Then expiratory capacity. Expiratory capacity is volume of air which can be expired after tidal inspiration. Okay, which can be expired after tidal inspiration. This is tidal volume plus expiratory reserve volume. This is around 1.2 to 1.5 liters on an average. Okay, now next is the vital capacity. Vital capacity, this is very, very important capacity of our lung. Okay, here the volume of air that is expelled from the lungs during a maximum force expiratory effort starting after a maximum force inspiration. So, vital capacity can be defined as the volume of air that can be expelled forcefully after forceful inspiration. Okay, this is the definition of vital capacity, and you must remember there is a one practical for only to calculate this capacity. Okay, that is vital capacity. So this is defined as the volume of air that is expelled forcefully and as rapidly as possible also. Okay, forcefully and as rapidly as possible after deep inspiration, that is called as vital capacity. Okay, so this vital capacity depends on many factors, as I told you, depending upon the age, gender. Okay, in males vital capacity is more because of the broad chest and more built body surface area. So vital capacity is more in males. It is around 4.5 liters. Okay, 4 to 4.5 liters. Whereas in female it is around 3.5 to 3.8 liters. Okay, so it depends on the gender, build. Okay, in children it is less, in adult it is more, and again in old age it becomes less. Okay, and in athletes or trained athletes it will be more. Okay, because of the strong muscles, respiratory muscles. Okay, so there are, and even posture will also affect the vital capacity. On standing position, vital capacity will be maximum because the venous blood pools in our lower limbs. Okay, so because of the less pulmonary blood, the lungs can expand more, okay, easily, and even the diaphragm can descend down because of the gravity in standing position. This increases the vertical length of our chest. Okay, so all this factor contribute, and vital capacity is maximum during standing. Okay, and it will be less in the supine position. This particular practical also you will do, that is effect of posture on vital capacity. So this is very, very important vital capacity. You have to read it thoroughly and understand it. So it can be defined as the volume of air that is expelled forcefully and rapidly after deep inspiration. Okay, and normal value is around 4 to 4.5 liters in male and 3.8 liters in females. Okay, now coming on to the last capacity, that is total lung capacity. The volume of air that is inhaled into the lungs after a maximum inspiratory effort, after maximum inspiration. Okay, that is the total amount of air which is present in our lungs after deep inspiration. So it is around 5 to 6 liter, that is around, that is equal to our pulmonary ventilation. Okay, so the total lung capacity has vital capacity plus residual volume. So our vital capacity is the product of tidal volume plus inspiratory reserve volume plus expiratory reserve volume. Okay, so the total lung capacity is a product of vital capacity plus residual volume. Sum of, it's not a product. Okay, sum of vital capacity plus residual volume. Is it clear to you? Okay, so you must remember their definition and their normal value. So these are the four lung volumes, that is the tidal volume, residual volume, expiratory reserve volume and inspiratory reserve volume. These are the four important lung volumes, and these are the four important lung capacities, that is functional residual capacity. Very important function of functional residual capacity is it helps in the continuous exchange of gases. Okay, then inspiratory capacity, expiratory capacity, and vital capacity and total lung capacity. So in this, which cannot be recorded by spirometry? I told you in volumes, residual volume cannot be recorded. Now you tell me, in these capacities, which capacities cannot be recorded by spirometer? Yes? Which cannot be recorded by
Capacity.
Residual
spirometer?
capacity,
Yes?
Capacity
functional
LC.
residual,
Functional residual capacity and
total lung capacity.
yeah, very
TLC.
good. Because as we cannot measure the residual volume, so these capacities also cannot be measured. That is functional residual capacity. It is a product of residual volume plus expiratory reserve volume, and total lung capacity also include residual volume. So very good. These are the Viva questions we will ask you very frequently. Okay, which lung volumes and capacities cannot be recorded by simple spirometry or recording spirometry? Then what if it cannot be recorded, what are the other alternative methods? Obvious next question. So you people find out this. Okay, if you find out what are the methods with which we can record the residual volume, then we can same method we can calculate the functional residual capacity and total lung capacity. Okay, I feel up to here it's very clear. Okay, so this is the graph. Okay, this is called a spirogram. Okay, so the instrument which you use for recording this is called as spirograph. Okay, spirograph is the instrument, and the recording or graph what we will obtain is the spirogram, and the procedure of recording is called as spirometry. Okay, you must remember these wordings. Okay, so the instrument is spirograph, the graph is spirogram, and the procedure is called as spirometry. Okay, so this you have to record it in your practical halls. Okay, so here you can make out the this is your tidal volume. Here it has been shown. Okay, so this is around 500 ml. Okay, so this is normal inspiration, normal expiration, normal inspiration, expiration, normal inspiration. This is one cycle of respiration. Okay, so this is our tidal volume. Okay, so what we in this is normal inspiration. Then what we inspire above the normal inspiratory level is our inspiratory reserve volume. Okay, and this is the normal expiration. So whatever we will expire beyond our normal tidal expiration is our expiratory reserve volume. Okay, I think you are understanding here. Okay, and whatever is remaining here is the residual volume. This will not take part in the here. Okay, this is the residual volume. Okay, and next is up to here. This is the vital capacity. Vital capacity involved IRV, TV and ERV. All these things including it is called as vital capacity. So it is defined as deep inspiration and deep expiration and forceful expiration, isn't it? So it involves a deep inspiration, okay, deep and forceful inspiration and rapid forceful expiration. So it involves IRV, tidal volume and ERV. This is our vital capacity. Are you understanding? Okay, so if we include residual volume and expiratory reserve volume, this becomes our functional residual capacity. Okay, and inspiratory capacity. Inspiratory capacity is our IRV, that is inspiratory reserve volume plus our tidal volume. Okay, I think now it is clear to you. Okay, so these are the different static lung volumes and capacities. You are going to record this in a specific paper graph we will provide to you. Okay, in that you are going to record it and you are going to calculate the different lung volumes and capacities. This is one of your important practical. Okay. Moving on to the dynamic lung volumes and capacities. Dynamic means I already told you it's the time factor is considered here. Okay, hence they are called as dynamic lung volumes and capacities. In that, first one is timed vital capacity, TVC, or it is also called as forced vital capacity, FVC. Okay, so it is the amount of air which is expired after deep inspiration, forceful expiration, that is called as post vital capacity, but here the time factor is considered. So we have components or we have subdivided time vital capacity into FeV1, FeV2 and FeV3, that is forced expiratory volume in at the end of first second. Okay, and FeV2 is forced expiratory volume at the end of second, and FeV3 is forced expiratory volume at the end of third second. Okay, so when we start expiring at the end of first second, how much we will expire? Okay, when and at the end of second, how much we will expire? At the end of third second, how much we will expire? That is the FeV1, FeV2 and FeV3, and this is the very FeV1 is a very important dynamic lung function which is used still today in a practical, in our day-to-day practice to find out the lung functions. Okay, it's very important lung function still in use. Okay, by the practitioners or physicians, still they will consider this to determine the proper functioning of our lung. Okay, so it is very important diagnostic dynamic lung volume. Okay, I will tell you, it helps in diagnosing which type of respiratory disorders in my further slides. Okay, so FeV1 is forced expiratory volume at the end of 1 second and its normal value is 80%. That means 80% of air we will expire in the first second itself. Okay, then normally FeV2 is around 95%. So about 95% of air we will expire at the end of second, and third FeV3 is around 98 to 100%. At the end of third second we will expire 100%, how much we want to expire. Okay, so that is the meaning of FeV1, FeV2 and FeV3. Okay, then one more dynamic lung function is forced expiratory flow during 25 to 75% of expiration. Okay, so normally it is called as FEF 25 to 75%. Forced expiratory flow during 25 to 75% of expiration. Normally it is 300 liters per minute, and FEF 200 to 1200. So it is around, it is also forced expiratory flow during 200 to 1200 ml of expiration. Okay, so that is called as FEF 200 to 1200. So this is around 350 liters per minute. And one more dynamic lung function is minute ventilation or pulmonary ventilation. So this is defined as amount of air breathed in or breathed out by our lungs per minute. Okay, that is called as minute ventilation or pulmonary ventilation. Okay, this is during quiet breathing, during normal breathing. So, minute ventilation or pulmonary ventilation is amount of air which is breathed in or breathed out during normal respiration. Okay, this is around 6 liter. Okay, 5 to 6 liters per minute. Okay, you can calculate this by multiplying tidal volume into respiratory rate. So how much is our tidal volume? Yes. How much is our tidal volume?
500 ml.
How much is our tidal volume? 500. Hello. Anyone?
500 ml.
Yeah, 500 ml. What is our normal respiratory rate? It is around 12 to 15 cycles per minute, isn't it? Normally. Hmm? So if you multiply 500 into 15, how much it will be? Hmm? Yes? How much it will be? 500 into 12 or 500 into 15. That is the range of our pulmonary ventilation. How much it will be? Yes? Fast. Hmm? Yes, how much it will be?
6,000 to 7,500.
Yeah, okay, that's what. 6 liter to 7.5 liter per minute. If you consider 15 is our respiratory rate, then it is 7.5. Okay, if you consider 12 is the, usually it is up to 14. 12 to 14 is our normal respiratory rate. Okay. Now that is one of the important dynamic lung function. Okay, now peak expiratory flow rate. Okay, this is again one of the simple but very informative dynamic lung function. So it is recorded not by spirometry, it is recorded by one small instrument called as peak flow, right? Peak flow meter. Okay. So with that you can record the peak expiratory flow rate. Okay. Now next is the maximum breathing capacity, or it is also called as maximum voluntary ventilation. Okay. Maximum breathing capacity is pulmonary ventilation is during quiet breathing. So maximum breathing capacity is here. You can take deep inspiration and deep expiration. Maximally how much you can inspire and how much you can expire. Then you have to calculate for 1 minute. So that may be around 90 to 170 liters per minute. So you can make out this much capacity our lungs are having, but normally we are ventilating only about 6 liter per minute. Okay, that means that much reserve we are having in the lungs. If time comes, we can breathe up to that level, okay, by our efforts. So maximum breathing capacity or maximum voluntary ventilation is around 90 to 170 liters per minute. Then pulmonary reserve or breathing reserve is nothing but maximum voluntary ventilation minus pulmonary ventilation. Okay, maximum voluntary ventilation minus pulmonary ventilation. So with this you can calculate one very important index that is called as dyspneic index, or it is popularly called as capital D, capital I, dyspneic index. Dyspneic index is nothing but maximum voluntary ventilation minus pulmonary ventilation divided by maximum voluntary ventilation into 100. Okay, normally it should be around 70 to 90%. Okay, if it is 90%, it's very good. If it is less than, dyspneic index is less than 60%, then the patient suffers from breathlessness. Dyspnea is nothing but breathlessness. Okay, so if this index is less than 60%, patient will be having dyspnea or breathlessness. Okay, so these are the very important lung volumes and capacities. So this I have explained in detail in my further slides. But right now, at least you remember the names of different dynamic lung volumes and capacities and their normal values. Very important for you people here is FEV1, okay, and minute ventilation and pulmonary ventilation. These things you must remember, okay, and dyspneic index. Okay, next, coming on to the FEV1. So as I told you, the lung form of FEV1 is force expiratory volume in 1 second. Okay, so it's very important diagnostic pulmonary function test. Okay, so maximum volume exhaled during the first second of expiration. Okay, so best indicator of obstructive lung disease means if the person is having an obstructive lung disease like bronchial asthma or COPD, chronic obstructive lung disease, then there is obstruction for expiration and expiration will be prolonged. Then FEV1 will decrease, isn't it? Normally we will expire 80% of air in 1 second itself, but the patient is asthma and chronic bronchitis, they will not expire 80% of air in 1 second. Okay, so they'll expire only 50%, 40%. With that, we can diagnose that the person is having if FEV1 is less, the person is having an obstructive lung disease. Okay, so with this, we can also make out flow characteristic of larger airways. So larger airways, whether they are normal, patent, we can make out by calculating the FEV1. Best expressed as a percentage of FVC. So we will express it as FEV1 divided by forced vital capacity, okay, into 100. This calculation also you will do in your practicals. Okay, we will show you how to calculate FEV1 in the practicals. Okay, so normally it should be 80%. FEV1 should be 80%. So should be able to exhale 80% of the vital capacity in the first second. Okay, and decreased in obstructive disorders. Okay, force expiratory flow, that is I told you FEF 25 to 75%. So middle, that is examine the middle 50% of exhaled curve. Okay, reflects degree of airway patency or condition of medium and small airways. Okay, it gives information about the condition of medium to small airways. It is also a early indicator of obstructive dysfunction. Normal value is around 404 to 5 liters per second. Okay. Now, FEF 200 to 1200, I told you. Average flow after the first 200 ml is exhaled. Okay. Good indicator of integrity of larger airway functioning. Okay. It also decreases in obstructive disorder. So in a computerized machine, you will get this automatically all those values. You need not have to calculate. But with spirometry, which you will do in your practicals manually, you have to calculate this manually. But in a computerized spiropack, okay, you will get all these values automatically. Okay, decrease in obstructive disorder and normal value is 6 to 7 liters per second. Now, peak expiratory flow rate, as I told you, it is done by one small instrument which is holding, that is peak flow meter. It is maximum flow rate achieved during an forced vital capacity used in asthmatic to identify the severity of area obstruction and guide therapy dependent on patient effort. So how much patient will forcefully expire? Okay, the values depends on that. Normal value is 10 liter per second or 600 liters per minute decreases with age and obstructive lung disorders. Okay. Now, maximum voluntary ventilation, MVV. How you record here? Okay, here you can make out the graph. It is a deep in. It is not a tidal volume type waves. Okay, these are our tidal volume. This is deep inspiration, deep expiration. Okay, so maximum inspiration, maximum expiration as rapidly as possible. Okay, amount of air moving. You cannot do this for whole 1 minute. Deep inspiration and deep inspiration, expiration. Why means the carbon dioxide washout occurs and person may become unconscious also. So you should never do this for whole 1 minute. So here also it has been shown amount of air in 12 seconds. So you calculate for 12 to 15 seconds only, then you multiply, calculate it for whole minutes. If 15 minutes this much, for 1 minute, how much it will be. Like that you are supposed to calculate the maximum voluntary ventilation. So patient breathe as fast and deep as possible for 12 to 15 seconds. Test for overall lung function. So this function, okay, this MVV test for overall lung function, ventilator reserve capacity and air trapping. Normal it is 170 liters per minute, decreased in obstructive disorders. Again it is decreases in obstructive disorders. Okay, this you can record by your spirometry itself. Okay. Next is, so, in which, what are the indications to do the pulmonary function test? So, what I told you till now, lung volumes and capacities, those are the part of the lung function test. Okay, so we have lung function test to assess the ventilatory functions. That is what I told you, lung volumes and capacities. So, there are tests to assess the gaseous exchange. Okay, that is carbon monoxide diffusion test and oxygen diffusion. Okay, so there are tests to assess the diffusion capacity, gaseous exchange, and there are tests to assess the pulmonary circulation also. Okay, so there are many tests, but lung volumes and capacities are one of the important part of pulmonary function test. So we will use this for following like medical diagnosis, surgery related evaluation, disability evaluations, public health, and for research purposes we will use this pulmonary function test, and studying the effect of exercise on lungs. We need this pulmonary function tests. Okay. So what are the contraindications to do this pulmonary function test? Okay, if the person has undergone recent abdominal, thoracic or eye surgeries, so you should not perform in them the pulmonary function test. And hemodynamic instability, okay, symptoms of acute severe illness like chest pain, nausea, vomiting, high fever or breathlessness or dyspnea, you should not do this. Okay, and recent hemoptysis is blood in the sputum, you are not supposed to do this. If the person is suffering from pneumothorax, that is air in the pleural cavity, recent history of abdominal, thoracic or cerebral aneurysms, you are not supposed to do this pulmonary function tests. Okay, normal values depends on height of an individual, weight of an individual, age, gender, male or female, race, and if effort dependent, how much effort the subject is doing, how much strong his respiratory muscles are. Okay, what are all instruction you are supposed to give to the subject before performing the testing? Okay, should not drink alcohol, should not smoke, do not eat a large meal, 2 hour prior to test, no vigorous exercise 30 minutes before test, do not wear tight, form fitting clothes, may need to remove loose dentures for tests, should wait at least 1 month post MI, myocardial infarction, consider impact of problem that may affect results, then bring a list of all medications, potentially withhold bronchodilators and corticosteroids before performing these tests. Okay, and these pulmonary function tests are, they are also called as LFTs. Lung function tests are a group of tests that measure how well your lung works, how well the lungs take in and exhale air, and how efficiently they transfer oxygen into the blood. Okay, so these BFTs are useful in assessing the functional status of respiratory system, both in physiological and pathological condition. It is based on the measurement of volumes of air breathed in and out in normal breathing and forced breathing. It is carried out by using a spirometer. So these are the, so left side, this is the traditional spirometer. Still we are also having this in our lab, and we are going to perform this and record the static lung volumes and capacities, and you are going to calculate even FEV1 by using this instrument. So we are having, this is a chymograph and paper is attached to it. In that you will get the graph, and here there is a writer. Okay, you will put ink in this, and there are two drums here. Okay, so one, this is the inverted drum. Okay, this is one double walled cylinder is here. Okay, metallic cylinder. In this we will fill 3/4 of water. Okay, we will fill 3/4 of water. Why we will fill water here? To make the container airtight, so air should not leak. Okay, for that purpose we will fill the water, and this is called as inverted cylinder. Okay, invert, it is made up of a light metal, that is aluminium. Okay, so when we expire, this will come up. Okay, so this will move up and down during respiration. So we will be having the mouthpiece. Okay, so we will hold the mouthpiece in our mouth, and we will take deep inspiration, and by closing our nose we will expire into our mouthpiece. Then this drum will move up and down, and accordingly we will get the graph in this. Okay, you will be doing this practical. Right now I am showing here, so you can see, you can adjust the speed, speed of the your chymograph, and you can calculate the time also. Okay, so this is the traditional spirograph, and nowadays the computerized system has also come. So in a very high tech hospitals, they are not using this traditional, only in physiology practicals. Some of the physiology practicals we are using it, but most of them are using nowadays the computerized physiographs. Okay, this is the advanced setup. Okay, in which you can measure the computerized pulmonary function tests. Okay, so now something about the spirometry. It is the spirograph is an instrument for measuring the air capacity of the lung, measurement of pattern of air movement in and out of the lung during controlled ventilatory maneuvers. Spirometer is used to measure the airflow, ventilatory regulation, ventilatory mechanics, and lung volumes during a forced expiratory maneuver from full inspiration. Okay, so I told you FEV1 we will use to differentiate between the obstructive lung disorders and restrictive lung disorders. So in obstructive lung disorders, the FEV1 will be less, whereas in restrictive lung disorders, the FVC will be less, but FEV1 will be normal. That is, 80% of whatever has been inspired will be expired. But FVC, restrictive, means the lung itself there is a problem. Okay, lung itself cannot hold much air, hence the vital capacity itself will be less here. But FEV1 remains normal. So by that we can differentiate the person is having obstructive disorder or restrictive disorder. So respiratory flow is below normal. Okay, So anatomical site can be identified where there is a obstruction, and some of the diseases which causes obstructive lung disorder, that is cystic fibrosis, bronchitis, asthma, bronchiectasis and emphysema. In case of restrictive lung volumes are reduced, okay, the diseases which causes the restrictive lung disorders are neuromuscular disorders, cardiovascular disorders, pulmonary disorders, and chest trauma or chest wall dysfunctions and obesity. All those things which compress the lungs may lead to the restrictive lung disorders. Okay. So PFT can help in diagnosing this disorder. I already told you. Okay. So what is the procedure here? Force expiratory manual is the common clinical approach. Results are found in patient chart or monitor. Common spirometric values are FEV1 and FEC, and FEV1 by FEC ratio is very important marker. Lung volume and peak expiratory flow rate are measured to differentiate obstructive or restrictive problems. Okay. Then procedure. Procedure is you have to sit straight, get a good seal around your mouthpiece so that the air should not leak from your mouth. Rapid inhale maximally without any delay. Blow out as hard as fast as possible into the mouthpiece. Continue the exhale until the patient can't blow no more. Expiration should continue at least 6 seconds. Abruptly you should not stop expiration in adult and 3-second minimum in children under 10 years. Repeat at least 3 technically acceptable times without cough, air leak and false start. Okay, you have to repeat 3 times and best among the 3 you have to take. So this is your normal spirogram. So this is the force expiratory volume, and FEV1 will be around 80%. You can make out 80% of FVC. Okay, this is the normal spirogram. So if FVC and FEV1 is less than 80, okay, total volume of air expired is approximately 80% within first second, that is FEV1. If it is less than 80, then there is some pathology. At this point, we can't decide obstructive or restrictive problem. So, identify an obstructive problem. Airflow reduces because of narrowing of airways, that is FEV1 is reduced. Spirogram is continued to 6 seconds to empty lung. FEC also reduced because gas is trapped behind the obstructive bronchi. Cardinal feature of obstructive defect is reduction in FEV1 and FEVC ratio. Okay. In obstructive diseases like asthma, FEV1 is diminished because of increased airway resistance to expiratory flow. The FVC may be decreased due to premature closure of airway in the expiration. This generates a reduced value, that is less than 80%, often 45. So if it is 60 to 80% mild obstruction, if it is 40 to 60% FEV1, it is a moderate obstruction. If it is less than 40%, there is a severe obstruction. So here you can make out FEV1 is reduced. Okay, so it should be 80%, it has reduced here. So this what you will get in a obstructive spirogram. Okay, so in a computerized thing you will get, okay, this is the expiratory wave and there is a obstruction. Okay. Restrictive problem. Restrictive disease can be caused by diseases of lung parenchyma itself. Like lung itself is fibrous. Chest wall diseases like kyphoscoliosis. Because there is a deformity in the chest wall and spinal cord, lung cannot expand. This prevents the full expansion of the lung. Therefore, FVC may be reduced. FEV1 will increase because of the stiffness of fibrotic lung increases the expiratory pressure and it may remain normal. Hence, expired air comes out very quickly, resulting with a high FeV1 by FVC ratio. So this ratio is more here. Okay. Restrictive. So you can make out FeV1 will be up to 80% or more than 80% in restrictive lung diseases, but FVC itself will be less. Okay. So this is the restrictive lung disorder you will get here. So forcefully fast it will be expired. So this is about the different lung volumes and capacities. So we will stop here, I think. Okay, you go back and read this in your whatever textbook you are having. It is given very simple in AKJ. Okay, if you are having AKJ today itself, you go through this and make a note of it. Okay. Okay, make a note of it. It's one of a long question it may be asked. Pulmonary function and different lung volumes and capacities. If you have any problem, you can ask me through WhatsApp or mail. Thank you. Stay safe.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Okay, thank you.